Hi, welcome back to Nursing 204 with Karen and Deb. Today, right now, we're going to talk about Foley catheters and Foley catheter insertion. So, initially, I want to talk about Foley catheters. Catheters are a rubber tube that are placed into the bladder via the urethra. And so, honestly, there are some differences between male and female. But a lot of the procedure is very much the same. So initially we're going to talk about Foley catheters. So just so you know, the larger the number on the catheter, the larger the catheter size. So if you have a 20 French Foley catheter, that's pretty large. If you have a 12 French, that's significantly smaller. And I have a couple of catheters here. Unfortunately, I don't have varying sizes. This is a 16. You will see at this end that there is a larger opening there. There's a hole in there. This little piece that's off to the side here is where you inflate the balloon. The balloon is what helps to hold it at the floor of the bladder. It helps to keep it in the bladder. Then this tube is, of course, the tube that goes into the urethra. There are holes on either side of this tube. There is also a little spot right here. I don't know that you can see this very well with the glare. Okay, there's a little spot right here that is the balloon. And when you put air in it, that will inflate. So that's kind of the anatomy of a Foley catheter. This is a red rubber catheter. Can you tell? Probably not. There are a couple things that are different about this. This is a more firm rubber tube. As you can see, there's no tail off here, which would be used, it's a port to be used to inflate the cuff at the end of the catheter. So that means there is no cuff on this catheter. So do you think that it would be challenging to keep this catheter in place without that cuff? And the answer is yes. You really need that little balloon inside to help to hold it in place. If you were having to use a red rubber catheter, you would have to make certain that you thoroughly taped this catheter to the patient's thigh so that it stayed in place. I've usually seen this more for men than for women, but you most definitely, it's a rare thing that you'll see this, but sometimes if the patient is difficult to insert a catheter, this will be used. Then another form, it's called a Tiemann. You see this little crook at the end of the tube here. This is a silicone catheter, so it's kind of a slightly opaque tube, but it has the port on it. It has the opening where it connects to the catheter bag. But on this end, you'll see it has that crook and it's at an angle. This is called a Tiemann. This is usually used for male patients. The reason for it is, I don't know if you can see, there's kind of a bulb there on the end. Men, oftentimes, as they age, they get an enlarged prostate. And the prostate is around the urethra, just below the entrance into the bladder. It's around that area. And what can happen is the prostate can get enlarged. Men can be more difficult to catheterize. So this is kind of like an introducer. It goes at an angle. You are able to insert that. Sometimes you have to do kind of a little gentle rotation to try and get the catheter all the way into the bladder. So this little structure helps for that to happen. So there is usually what we've normally seen, the gravity drainage, the collection bag that holds 2 liters worth of fluid, I believe it is. And then also too, sometimes patients that have a catheter that is long-term, oftentimes patients will have a leg bag. So they'll disconnect from the regular gravity drainage bag, in the morning, and usually there's an extension tube, but this attaches to the end of the catheter here. These elastic straps wrap around the leg, the thigh, and then this is where you would empty the bag. So those are usually the two forms of bags that you will see. There are also straight cath kits. Some patients are on a bladder program where every 6 hours they will self-catheterize and empty out their bladder. So you will see a different setup in that way. And believe it or not, of course, our procedure is sterile, but for patients that self-cath, it's usually considered a clean technique because it is all their germs. It's all their bacteria, which they're used to. So oftentimes with that, it's just a clean technique. So let's get started. There are, oops, I better say seated, sorry. There are catheter kits. This one has everything in it. The catheter is attached to the bag. It's complete. Probably what you will have in the facility is you will have to put some pieces together. So probably what you have is a catheter insertion tray. Then you would need to get a catheter. Sometimes they have the collection bag in there. Sometimes you need to get a collection bag as well. So those are a few, there's differences, but those are things that you would definitely want to be paying attention to and make certain that you have before you go into the patient's room. Also too, I highly recommend taking 2 catheters into the room. And we'll talk about that more in a little bit, but I strongly recommend that you take 2 catheters. Okay, so I'm going to use the complete setup. So initially, you're going to introduce yourself to the patient, of course, and let them know exactly what you're going to be doing. Then you will want to get set up. You've brought all your equipment in. You're now going to want to get set up, get the patient prepared. The patients feel very vulnerable when you put a Foley catheter in them. You are getting into very vulnerable places. And if people have had any sort of past history with any sort of sexual abuse or anything, this oftentimes can be very frightening to them. So make certain that you are telling them, you know, what you're doing. Don't startle them, no surprises. Keep it professional, but keep it comfortable for them. So one thing I like to do with my patients when I'm getting them ready, after telling them what I'm going to do, then I like to get a blanket or a towel to put up over the top of them. This just kind of helps to give them a little bit of a sense, even though you're totally exposing their perineal area, it just gives them a sense of comfort and privacy because this is very invasive. So the next thing that you'll want to do is you'll want to get your patient positioned. So for women, you know, we all have had the gynecological exams. You want to bend their knees up and you want them to create frog legs. For men, they can basically lay on their back and that is comfortable. But for women, you definitely want to try and get them in this sort of position. Now then, as we deal with our elderly patients, they aren't very flexible. So oftentimes this is very difficult and challenging. There was a patient one time that I had who had a prolapsed uterus, and I literally had to get her up on her hands and knees so their uterus would fall down so that then I could put a Foley catheter in her. So you will find that this may be the optimal positioning, but you have to get pretty creative sometimes. So initially, bring some warm wash rags with a little bit of soap on them, and you want to just do regular peri-care. So wash and get a fresh side, wash one side, wash the other side, get another clean side, spread apart the labia, open it up, and clean down. Then you definitely want to make certain that you have a rinse rag and rinse this off. Make certain that you aren't leaving any soap or any residue. Of course, changing your sites. And then with your third wash rag, you would want to just pat it dry a little bit so that it's pretty dry, most definitely. So then you're going to want to start getting your tray opened. Now then, this is a sterile procedure. So I just did clean care. I'm going to remove my gloves, hand hygiene, and sanitizer. Get that, get your hands clean and definitely ready and prepared to now set up a sterile field. So this is a little challenging with our screen, but this tray is considered sterile. I'm going to do it on top of Annie's legs here for a moment so you can see. So I'm going to open it up. And this cap tray has been opened before, and I'm realizing that there are no sterile gloves in here. So, my Karen, bless her heart, she is going 6.5, please. She's grabbing some gloves for me. So, thank you, thank you, thank you. So usually the gloves are laying right on top. So I would fan fold it open. There are choices for where you set this tray. You can set it on a bedside table right beside you. I like to place it in the area where it's closer to me where I'm working with it. I'm always concerned that I'm going to contaminate the field if I'm doing a bedside table and then to the patient, because I'm starting to turn my back on my sterile field, and I don't want to do that. So I'm going to put on sterile gloves, and with this I will be breaking sterile technique as I'm going to need to move the kit. I just want to have things in place so that you can see how it is in the kit and how it's set up. So, and a very important point. So as you can see, my name tag's kind of hanging down in my area. I'll flip my name tag back up over my back, or oftentimes there's a clip on your name tag. Make certain that you don't have any objects that once you lean over, it's going to fall down into your sterile field. So I'm going to go ahead and put on my sterile gloves. Maybe. I love it. Okay. I forget, these gloves are a little bit smaller than usually what my size is. Okay. There we go. So I do have the paper from opening up my gloves. However, I'm going to bomb drop that onto the floor and just get it out of the way. So when you open up the tray, this is what it looks like. So you have betadine swabs for cleaning the patient. You have lubricant. And I highly recommend grabbing a second packet of lubricant when you go to the supply room. grab 2 catheters, a kit, and I recommend getting more lubricant. Then with this kit, there's a little tray here. It has this syringe, which has sterile water in it. You use the sterile water to inflate the balloon to the catheter. So you want to hang on to that. It also has this little container. This little container is used, maybe the doctor's saying, I would like for you to get a urine specimen after you get the catheter inserted. So this could be used for that. Then underneath the tray then is my catheter tube and my tubing, which is connected to the gravity drainage bag. This is all connected in all one complete system. So now then I'm going to get her repositioned so we can do the process. Okay. So we're going to put Jane's legs back into frog leg style. Okay, so there is usually a sterile drape that is in this package too. I highly recommend that you put a sterile drape in there, and how you'll want to do that is you, with your sterile gloves, you can wrap it around, protecting your hands and keeping them sterile, and you can tuck it down in. So we have the extra large. We have the extra large drape here. So what you can do is you can wrap the sterile drape around your hands and tuck in under. There we go. Nope. Okay. Okay. So now then, you can kind of flatten it out on top. So I'm going to have my, one thing you always want to do right from the get-go to make certain is you want to check your balloon. So you can go ahead and attach this. This is all sterile. You don't need to wipe this valve or anything. Go ahead and attach that, and then you want to inflate it and make certain that your balloon inflates. It's going to always inflate lopsided. If you can see that, it's going to inflate lopsided, but you want to make sure that there's no leakage of the sterile water. So just let go of that and let it release and go back into the syringe. So I'm going to go ahead and open up my iodoform, their iodine. Get that ready to go. Oh, these always fling iodine. Like that. Okay, I get that set up. Then I get my lubricant. Fell to the bottom of the box, don't you know? Get my lubricant right here on your sterile field. And I recommend putting 2 packets down. You can't have enough lube with these, most definitely. It's different from an NG tube. So anyhow, get your lubricant all set up. Then I go ahead and take my tube and I start getting it lubricated and ready to go. So I'm afraid I'm gonna run right into that iodine. Okay, so for women, our anatomy, thank you. Our anatomy is pretty challenging sometimes, especially with our little elderly people. It really can be a bit challenging. There can be, like I say, there can be some issues with the prolapsed uterus. There can be a lot of labial folds down here. There can be swelling and edema. There can be retraction of the urethra so that it is way back in there and hard to visualize, most definitely. But as best you can, you want to spread apart the labias for women, and you want to visualize the openings. So get your landmarks. You'll look for the clitoris on the woman. And when I was learning this, I was told under the hood. So the clitoris kind of, there's a little bit of a U-shaped piece of skin that hangs down a little bit. And the urethra is right under that hood. So that's kind of what you want to look for, looking under the hood. Then you'll see the vaginal opening. Then you'll see the rectum. So for the woman, you want to spread apart the labia as best you can. Then you have 3 swabs here you're going to want to clean. And you swab on one side, and then you balm drop. And you swab on the other side, and you want to balm drop. And then you swab directly down the middle for the woman. And then you balm drop. So now you've cleaned it, and now you want to go ahead and insert the catheter. So also too, you may want a buddy to help you for holding the legs. Also too, when Karen said you may not use your camera for pictures, sometimes people use, or their cell phone, excuse me, they use their cell phone for lights. That can be concerning to patients if that's what you're doing. So make certain that you're talking to your patient, explaining things. I highly recommend though, just get a pin light, and then you avoid all that, because they don't want to feel like you're invading their privacy and taking pictures of them. So anyhow, so for women, you will find the opening. Thank you. Okay. Then go ahead and insert. And you want to keep going. Oftentimes people say that you can go until you get a urine flashback, and of course you can, but you want to make certain that that tube is all the way up into the urethra and up into the bladder. So I always secure it with this hand. I inflate the balloon, and now the best practice recommends only 5 milliliters. So only put 5 mils in there. Then you can deflate, excuse me, you can disconnect that, and you'll then pull the tube back until you meet resistance, and then you just stop right there. Now then, there are devices to help to hold the catheter to the leg. I highly recommend doing that because it's easier for catheter tubes to get caught. So there are patches you can put on the leg, or Velcro straps, things that you can put on the leg to help with securing the catheter. So documentation, you would want to document date and time. You'd want to document what size of a Foley catheter you inserted. You want to document how the patient tolerated. You'd want to document what the color, odor, and amount of the urine is. Are you seeing any blood clots? Are you seeing white fluffy sediment in the urine? That would tell you that potentially there might be some bacteria growing, that there might be the concern for a UTI. So just paying attention to what you're observing as you start seeing the urine. Then you want to give it a few minutes for the urine to go into the collection bag, and then do your initial output after insertion. You know, did they have 500 mils? If the patient had not been able to void for 8 hours, you know, it very well could be that if you palpated the abdomen, you're feeling distension over the bladder area, and they may feel a huge sense of relief once you have emptied their bladder, and they're a lot more comfortable. So that is some documentation tips and what to be aware of as far as for a woman is concerned. Afterwards, you would want to clean the area, and then of course gently put the patient's legs back down and get them in a comfortable position. For males, males are a little different. So I worked with a urologist, and he gave me a lot of tips about catheter insertions. For males, he always said, point the penis to the gods. So you want to hold the penis in an upright position. You want to make certain that you're holding it pretty steady. You don't want to grab it tight, but enough so that you have a pretty firm hold, so that you're able to then insert the Foley catheter. Some males are uncircumcised. You may have to worry about pulling back the foreskin and gently cleaning around there. There can be a lot of white sediment that can accumulate on gentlemen who are uncircumcised. So you want to pull back the foreskin when you're doing pericare before you do the catheter insertion. You want to pull back the foreskin and make certain that you're getting them clean. After you have inserted the Foley catheter, it is imperative that you pull the foreskin back over and pull it back to the original position. That can create a lot of problems if you don't remember to do that, most definitely. So you want to hold the penis to the gods, most definitely. Hold it straight upright. You go ahead and you start inserting the catheter. I learned from Dr. Skeeters that you want to go all the way to the hub with male catheterizations. The reason for that is because at the place where there may be prostate enlargement and the opening is narrowed, that catheter tube, this is just a soft rubber. That catheter tube can do a U-turn in there and be coming back out. It could be getting some urine because you have a tube up there by the opening. Even though you haven't gone into the bladder, it still could collect some urine and make it look like you're there. So you do not want to inflate the balloon while the balloon is still in the urethra. You will cause great damage. So make certain, put the catheter in all the way to the hub, and make certain that you're getting urinary output, and then you can go ahead and inflate the balloon at that point, and you can do a gentle pull on the tube till you meet resistance to stop. Yes, thank you, Karen. So yes, sometimes with males, they can have a muscle spasming of the urethra and they will clamp down. And so sometimes you just have to sit and wait for a minute. Just be patient. Talk to the patient, make certain that they're doing okay. Just give them a moment to catch their breath before you try and insert it further. But yes, thank you. Yes, most definitely. There can be some muscle spasms, very much so. So now then, to remove the catheter, you'll want to put, it doesn't have to be a sterile towel under their buttocks area. It can just be a clean towel. You'll want an empty syringe. I still have some fluid in here from inflating the balloon, but I'll just reuse that. So what you want to do is you want to go in. First of all, I recommend you read in the chart how many cc's of fluid are in there. You definitely need to know how many you're wanting to take out. So insert the syringe into the valve here, into the port, pull back. I am going to get a full 5 mils back, so I should have deflated the balloon. If you start to tug on this and you feel resistance, stop. Do not try and pull it out. You could cause considerable damage. If you meet resistance, if you double check and make certain that you have all the fluid out, get a new syringe and see if you can draw back any more fluid. But if you cannot pull it out, then please stop right there, secure the tube, and call the doctor and see what they would like to do. It very well could be that the patient may need to go to the hospital, something may need to be done to remove the catheter, but most definitely do not force the tube to come out. Yes, it could tie in a knot, absolutely, absolutely. So gently pull this out. You don't want to whip it out and fling it all over. Usually patients just have a mild sensation of you removing the tube. There's usually not pain that's involved with it. Then go ahead and clean your patient and get them repositioned and get them as comfortable as possible. Then pay attention. Make certain that you still are getting urinary output even after you've inserted it. Make certain that you're continuing to get urinary output. Make certain that the patient doesn't have any sort of distension in their bladder. Make certain that the patient isn't complaining of pain. Sometimes patients will complain of a little bit of stinging just because you got into a very sensitive personal spot, and it can irritate a little bit. So watch for blood tinge also. Sediment, like I was saying, make certain that you're paying attention to what the urine looks like, and call your doctor if you're seeing something that does not look appropriate. So, okay, thank you very much. Bye-bye.